All right, we're going to start with COPD. It's a quick little overview for you. COPD is chronic obstructive pulmonary disease, and it is characterized by chronic airflow limitation that is not reversible. Almost 14 million Americans have COPD with an annual cost of $50 billion annually, and it is the fourth leading cause of death in America. So the pathophysiology of this, there's two different pathophysiologies depending on whether or not you have emphysema or chronic bronchitis. So it's basically inflammation and narrowing of the peripheral airways, which lead to loss of pulmonary function, specifically your forced expired volume over 1 second, not 1 minute. That should be seconds. So let's try this again. It's inflammation and narrowing of the peripheral airways, which leads to loss of pulmonary function, specifically the loss of forced expired volume in the first second. Emphysema, they are grape-like clusters at the end of the bronchiole, and they become abnormally enlarged with destruction of the alveoli, which is considered the functional unit of the lung because that's where your interface takes place for the carbon dioxide and oxygen. So that is what happens with emphysema. Then in chronic bronchitis, a person will have a productive cough that is present for 3 months, and it has to be present in 2 consecutive years. And this chronic mucus hypersecretion occurs, which causes a decline in lung function, exacerbations, and infection. And basically the end result of both forms of COPD is you're going to have impaired gas exchange. In health promotion and disease prevention, smoking cessation is your biggie. Always, always, always. You're going to avoid secondhand smoke exposure. You want to use PPE, so you want to instruct people to use personal protective equipment if they are going to be doing anything that would expose them to smoke or dust particles. If they're like a coal miner, they need to wear their respirator mask. Those are examples. And then you also want to encourage anybody that has a chronic respiratory disorder to get their influenza and their pneumonia vaccinations. Your COPD risk factors, well, smoking is your biggest risk factor, primary risk factor. You also have age thrown in there. Your older clients have a decreased pulmonary reserve, and that is due to normal lung changes that occur. Other risk factors, occupational dust and chemicals, air pollution on the inside and outside, and then the genetic risk factor is this alpha-1 antitrypsin deficiency. It is pretty rare, so the biggest takeaway from risk factors is that generally COPD is a preventable disease. And the way that it can be prevented is by not smoking, because that's your biggest risk factor. But there are other people that have COPD that have never smoked a day in their life, and they most likely they've worked in a mill or some kind of plant that exposed them to air pollution. So your most common manifestations of COPD are dyspnea, chronic cough, and sputum production. The diagnosis of COPD is going to be based on lung function testing, and of course, generally, unless you're going to work in a pulmonary office, nurses do not do lung function testing, but we still need to know what the diagnostic criteria for COPD is, and that is a forced expiratory volume of less than 80%, which that is your diagnostic criteria. And then you have a ratio, a forced expiratory volume over forced vital capacity ratio of less than 70%. So expected findings. Your common findings are exertional shortness of breath. The more severe the COPD, then the shortness of breath will start occurring when the patient is resting. But if it's mild to moderate, they will have shortness of breath with exertion. A productive cough, hypoxemia with decreased oxygen level. Hypoxemia is decreased oxygen level in the blood. Then they could also have a decreased oxygen level by pulse ox. You might hear, well, you will hear crackles and wheezing, especially as it progresses, and then you're going to have tachypnea that is shallow with accessory muscle use. Once the COPD progresses to the late stage, you're going to see a barreled chest with hyperresonance on percussion. The barreled chest is from changes that occur in the pulmonary system. With somebody that has emphysema, they're going to be more malnourished looking. And with somebody that has the chronic bronchitis type, they're going to be more obese looking. Also in the late stages, you're going to have clubbing of the fingers and pallor in your mucous membranes, as well as cyanotic nail beds. So this is just kind of like a picture to see the differences between a blue bloater and a pink puffer. If you are curious as to why the blue bloater is obese and the pink puffer is more malnourished, there is a link in the notes part of this slide that will explain it, but it's not something that you really need to know. You just need to understand that your person with emphysema they're not going to have the VQ ratio issue like the bronchitis person is going to. So they are considered, they don't have the hypoxemia really because of that. So they're pink, they're the pink puffer, and they're going to generally be older and thinner. They're going to have severe dyspnea and a quiet chest, and their x-ray is going to be hyperinflated. It's going to show hyperinflation with flattened diaphragm. With your chronic bronchitis, they are going to have an elevated hemoglobin. The elevated hemoglobin is from smoking, and it is also because of the low oxygenation level in the blood. So that's why your hematocrit and your hemoglobin are going to be increased. They are going to be more cyanotic and overweight, and they're going to have peripheral edema, especially if they develop a complication of right-sided heart failure because of their COPD, and going to have more of the lung sounds, the continuous lung sounds of bronchi and wheezing. So with your laboratory and your diagnostic tests, your laboratory test, you're going to have the increased hematocrit, which I talked about on the last slide. It's going to be increased hematocrit and hemoglobin. Your sputum culture, they'll do to see if there is any infection, as well as a white blood cell count. So those are not indicative of COPD. They're indicative of infection. ABGs can be used to see how pervasive the COPD is. Somebody that has an acute exacerbation might be significantly hypercarbic, so they might have an increased CO2 level in the blood, but a lot of people with COPD are what we call retainers, CO2 retainers. So they walk around with an elevated carbon dioxide level in the blood of like 55. 60, just depends. And as the disease progresses and gets worse, that level can get worse. But that's why you draw ABGs, just to see what the oxygen level is, CO2 level is, to see if they're compensating. And then you're also going to look at their electrolytes. With your diagnostic tests, you, again, why do I keep doing over 1 minute? Forced expiratory volume over the first second, not 1 minute, compared to forced vital capacity. Forced vital capacity is used for classification. So forced vital capacity is basically how much you can hold in. So this ratio, as this ratio decreases, then COPD worsens. In somebody that is mildly symptomatic, that ratio is going to be 70%, but in somebody who is moderate to severe COPD, that ratio can be less than 50%. We can also look at the chest x-ray to see if there's any changes in their pulmonary system, look at pulse oximetry, and then for somebody who doesn't have any risk factors, they might look at the alpha-1 antitrypsin level to see if that's what's causing the COPD. So patient-centered care. Positioning. I can't say positioning enough. So somebody that is short of breath, COPD, asthma, whatever, you're going to sit them up. Why are we sitting them up? It maximizes their lung function. It maximizes how much they can take in and how much they can let go. With COPD, we want to cough, turn, and deep breathe. One way to do this is via the incentive spirometer, but you can just have them cough. And there are instructions on coughing I have it right here. Box 11.6, box 11.7, and box 11.8 in your Honan book has different types of adequate coughing, adequate breathing exercises, so you should look at those to see how you can educate. Give oxygen as prescribed, but again, you want to be cautious with O2 administration because it's not the hypoxic drive that these people have that they use to breathe. There is a whole slew of there's like 3 different mechanisms. And if you really, really want to know about them, there's an article under resources that talks about it. But it's not the hypoxic drive. That's not what it's called. But yes, they are, after they get to a certain point, it's the CO2 in the blood that drives their mechanism for breathing. So you can give them too much oxygen. But please be mindful that if somebody is tripoding, they are sitting straight up, they are using their accessory muscles, they are sweating because they can't breathe, they're tachycardic. Give them some oxygen. Don't be scared. They obviously need oxygen. Their oxygen sat's like 80%. Like, don't be scared to put them on some oxygen. It's okay. But if you have a patient that is not symptomatic, they're not tripoding, they're not struggling to breathe, their SAT's 88%, 90%, they don't need it. But don't be scared if somebody is having issues. Make sure the patient or the client receives breathing treatments and other medicines as prescribed. Contact your respiratory therapist if you need to. Monitor for skin breakdown from these medical devices that we use, such as BiPAP, nasal cannula, any type of oxygen device on the face can cause some skin breakdown, so these things need to be monitored on a regular basis when you're doing your assessment that you can do up to 3 times a day, just depending on where you work. Make sure you promote adequate nutrition because people with COPD, they get very short of breath, especially the more severe the COPD is. They get short of breath with eating because it takes energy. So maybe they need some high caloric, high protein food. And monitor their weight and note changes. And we already talked about practice breathing techniques. Look on 357 to 359 for that. Other things about patient-centered care. We have positive expiratory pressure device, also known as a flutter valve. This helps the client to remove any type of secretions they may have. They inhale deeply and then exhale through the device. While exhaling, a ball inside moves, which causes vibrations, and those vibrations they help loosen the secretions. Then we have exercise conditioning, and the way we encourage this is it improves pulmonary status and the cardiac status of the patient. It helps to strengthen their lungs. What we encourage them to do is walk until they're short of breath and then rest. When that shortness of breath subsides, then they can resume walking. They should walk about 20 minutes every day, 2 to 3 times a week. And then you want to tailor it for the older individual. Be supportive and encourage verbalization of feelings and increase their fluid intake, because somebody that has COPD needs to increase their fluid to almost 3 liters per day. And the reason they need to do this is it helps to liquefy the secretions. Box 10.2 in your Honan book on page 293 talks about incentive spirometry. Please know how to use incentive spirometer and how to educate on incentive spirometry, because it is very important. If it's sitting at the bedside and you're in doing your assessment, you need to encourage them to do it. It helps to promote lung expansion. So I'm not going to read this slide to you. You know how to read, and you can look at that book, that page number. I'm telling you right now to look at it. There are different medicines for COPD and asthma. Bronchodilators, anti-inflammatories, and mucolytics. So for COPD, the bronchodilators, we have short-acting beta-2 agonists, also known as SABAs, and they provide rapid relief, and you use them when you have an attack. So they are basically a rescue inhaler, is what they're called in lay terms. The most common one is albuterol. With albuterol, you're going to watch for tremors and tachycardia, because unfortunately albuterol causes that, because the way it works is by dilating the bronchioles, and that has an effect on the cardiovascular as well, and it causes the tremors and the tachycardia. Other forms of bronchodilators, we have the cholinergic antagonists, anticholinergics basically, and they are used for prevention, and they help increase bronchodilation, and they will dry up pulmonary secretions because they are anticholinergics. So some things that you may want to do is teach them to suck on hard candies when they are having to use these, since they will dry them up. They can also get palpitations with them, because they're going to affect the they affect the sympathetic nervous system. You want to teach them to increase their fluid intake with these, because again it will dry them up, and to report headache or blurred vision, because those are signs of toxicity. Then with methylxanthine, which I have not seen very much of, because it's a last line medicine and it's only used when other medicines have failed. The most common one is theophylline. I think I've seen like 3 people in 13 years being on this. So just know that it's a narrow therapeutic range, and that toxicity can occur, and signs of a toxic theophylline are tachycardia, nausea, and diarrhea. Your anti-inflammatories, we have corticosteroids. We've talked about corticosteroids quite a bit. Some examples: fluticasone, prednisone, Decadron, Solu-Medrol. It's given systemically, so it's given IV, given PO. There's even inhaled corticosteroids. Side effects, please know your side effects of steroids. It will be on NCLEX. It will be on your med quiz. It will most likely be on this test. It will be on your final, because we've talked about these a lot. So immunosuppression, fluid retention, hyperglycemia, hypokalemia, and poor wound healing. Prevention, anti-inflammatories, your leukotriene agonists, your mast cell stabilizers, and your monoclonal antibodies are more for asthma, because they, like leukotriene or leukotriene and your mast cell stabilizer, that is more with your immune system, so they're more for asthma. With any type of anti-inflammatory medicine, you want to increase their fluids intake with food. Make sure, if it's inhaled steroids, that they have good mouth care, because inhaled steroids can cause thrush, and you want to tell them to not discontinue the IV or the PO suddenly. It needs to be tapered. Mucolytics are going to help thin secretions and you should increase fluid intake when you are helping to thin your secretion. Some very common mucolytics are, there is the nebulizer form of acetylcysteine. It smells like rotten eggs. It is so awful. But it will help cough up those secretions, help thin them out so they can cough them up. Then the oral form is guaifenesin, and like, what's the, not Mucomist, Mucinex. So they can take Mucinex, that's generally twice a day, and it will help thin out the secretion so they can cough them up. Meter, dose inhaler, and spacer. Know how to use it. Box 11 through 4, page 351. Not going to go over it. There it is for you to know. Client education. Remember that the older adult can get debilitated and they may need assistance with everyday things such as so you need to make referrals for these people. So like Meals on Wheels is a referral that you can make. Home care could possibly be needed, especially if somebody is on home oxygen. So they need to be able to have adequate referrals for home health, be able to get their supplies. You want to educate them on the importance of high-calorie, high-protein diet, instruct them on the importance of hand hygiene, because hand hygiene is the #1 thing we can do to prevent infection. Encourage rest periods, because these people get tired a lot easier. They become more fatigued easily. Promote smoking cessation, promote smoking cessation, promote smoking cessation. Reinforce the importance of taking medicines and give them instructions on the medicines. So know what the medicines are for, what they need to look out for, because you need to give them education about it. You need to encourage routine vaccinations, namely flu and pneumonia when it comes to respiratory issues. Educate on the flammability of oxygen. Hey, don't smoke around it. And most of all, you want to be supportive about things. So we can have a few complications from COPD. Respiratory failure, respiratory infections. We can have acute on chronic COPD. So look at your respiratory failure slide for that. And then also the person with COPD can develop cor pulmonale. So I'll talk a little bit about that in a minute. So the basic nurse, the generalist nurse, needs to be able to recognize respiratory failure because, when it happens, they need to go to an intensive care unit. And be persistent with the doctor who doesn't believe you, because you're with the patient all day. They're not. So, somebody that is progressing into respiratory failure, they're going to have severe shortness of breath that does not respond to treatment. So you want to give them treatments to try to get their shortness of breath better, but if it's not improving, it's time to go. This person is going to be at first tachypnic, then bradypnic, and then it's going to lead to apnea. They're going to have hyperventilation that declines to rapid, shallow breathing. They're going to be anxious because they can't breathe. Imagine how you would feel if you couldn't breathe. They're going to have LOC changes because they can't get oxygen to their brain, and so they're having that impaired gas exchange, and it's impairing their ability to think. Their hypoxemia is going to get worse, and it's not going to respond to oxygen therapy, and eventually they're going to have muscle fatigue, and they're going to use increased accessory muscle use. And you might not even notice this at the beginning because the increased accessory muscles, it's just so mild, but as it gets worse, the accessory muscle use is going to worse. And they're eventually going to get to sudden intensification of respiratory movement. So basically, their abdomen is going to be moving inwardly on inspiration. It's just, they're going to be breathing with their abdomen. Respiratory infection, which is very common with COPD. Make sure you administer oxygen as needed, assess and monitor, administer antibiotics as prescribed. Remember to always do blood and sputum cultures before administration of antibiotics. Teach these people to avoid crowds and promote the flu and pneumonia vaccine. And then with COPD, they could develop cor pulmonale. And cor pulmonale results because the lungs or the pulmonary vessels are diseased. So they have air trapping, airway collapse, and stiff alveoli, which lead to increased pulmonary pressures. Their blood flow through their lungs is difficult, and this causes the right atrium and right ventricle to enlarge, and they develop right-sided heart failure. So they are going to have all of the right-sided heart failure symptoms, such as enlarged liver and spleen, increased peripheral venous pressure, fatigue, ascites. They're going to be not wanting to eat because they're going to have like all this fluid around their belly. They're going to have weight gain even though they're anorexic because everything is just fluid filled. Oh, and there's my references. I guess I'm done. So, COPD. And then asthma will be next. So I hope you've enjoyed this, and I will talk to you in a minute.